Hello, everybody.
Welcome back to the Other Side Lifestyle Podcast with Jim and Aram. Everything that we just talked about was not recorded, thank God. My son would be traumatized later in life if he ever heard this, or if his friend's parents were listening to it in the car one day.
I don't think we're at any risk of anybody listening to this anymore. So
No,
okay.
My parents only. They're down to my parents. I'm just kidding. Jenna has a fake degree from Duke University on the wall behind her. She's wearing a white jacket, so you're supposed to believe things she says. We want to thank Adam Badger, our friend, for introducing us. He lives right down the street from Dr. Hume's office. And he he was like looking through your windows or something.
I can't confirm or deny that, but
can't confirm or deny. And then you were on his podcast, and he said that it was great and that we should have you on. So we are excited to have you. What do you doctor?
Yeah, what do you doctor?
Nurse practitioner. I'm not a doctor.
Oh, never mind. All right. Thanks for your time today.
Much less that, to be clear. I specialize in obesity medicine, so hot topic for a lot of people. But weight management, metabolic diseases, all the way to nutrition. I don't do exercise plans. I'm not a personal trainer, but it's also going into relationship with food and lining people up with resources they need. So therapy to improve relationship with food. So we hit a lot in 6 Pillars Health. It's not just, here's how you lose weight. Good luck. It's a lot of hands-on, high touch points. So it's kind of the overview.
So you said 6 Pillars Health. Is that the name of the company
my practice?
Your practice. Okay.
So I opened up 6 Pillars Health. Yep. And 6 Pillars Health just talks about the 6 pillars of health. Not assuming that you didn't know that, but just so that anybody else.
Well, tell us what the 6 pillars of health are.
Yeah. So nutrition, exercise, sleep, stress management, avoiding risky behaviors, and emotional health.
Let's talk about number 5.
Risky behaviors.
Let's talk about number 5.
No relation to what we were talking about before.
Yeah.
It's funny because it's the way that I discuss my coaching is it's based off of 3 pillars, but there's 2 sub pillars per, and I think that falls directly in line with what I think anybody with any experience or half a brain who does nutrition and fitness understands about human psychology and physiology, is that it's not one thing. And I think when your patients come to you or my clients come to me or Jimmy, they're like, well, what's this one thing I'm missing? And I'm like, you're missing a lot of things.
Yeah.
And most of them are rooted in your psychology and your belief system, and they have very little to do with what you think you believe you know about food.
Yep.
So I want you to start to talk about, especially here, because I think this is the best part of the conversation, is what are some of the misconceptions that get brought to you that you then have to dismantle to get people back on the right track?
That their metabolism is broken.
Yes, the dinner plate theory, it just shatters.
Uncontrollable cravings.
Yep, should be locked up for those.
They, assuming that there's a thyroid issue, or that their cortisol levels are the reason for things happening.
In your professional opinion, does Aram have cortisol face, or is he just taking too many anabolics?
Plead the fifth on that one.
Right. It's called a beard, Jimmy. It's covering up my cortisol face. And if I fucking have to hear the term cortisol face one more time, I'm going to punch somebody through my computer.
Yeah, I do have to talk, realistically, like I have never seen it ever. I've never had
until today.
Until if
today?
You have a tumor, but how many people actually have that? Yeah. I have never had to diagnose it. So
yeah, we that's a lot of the big ones. So let's deconstruct kind of one at a time. So broken metabolism.
Yeah.
From what I've now been reading, from what anybody in this industry I think that understands the business has been reading, we don't see any significant metabolic slowdowns until after the age of 60. And even then, it's immeasurable at best. So what is it about the metabolism that seems to be so wildly misunderstood?
Um, I'll tell you, a large majority of my patients are females, and a large majority have spent years and years and years trying to be as small as possible, which means crazy dieting, right? Like over restricting, cardio focused. So they come in and their bodies, they have a very low muscle mass and a high percentage of body fat by the time they come to me. And then they have a horrible relationship with food, right? And I'm saying this because it's the demographic. It's not to point fingers or judge or to say, oh my God, how could you think that? Because if that's how your brain is working, if that's what you saw your parents doing, how do we change that? How do we unlearn those thoughts and say, no, we got to be eating more to be able to have energy to do X, Y, and Z, to go to the gym, to change your body composition, to be able to live your life, right? So when people come in, the broken metabolism, I have to really start and say, let's do a body composition scan, just to give you a visual of where your percentage of body fat is and your skeletal muscle mass. And from there, they're like, wow, I'm average at best with my skeletal muscle mass, but my percentage of body fat is very, very high. So it's not that your metabolism is broken. It's not working as well as it could because your skeletal muscle mass is so low. It doesn't have to do anything, right? Like you're just kind of hanging out. So having that hard talk and saying, things change. You're not 25 years old anymore. We do have to talk about that, but also at the same point, having the glasses of wine because you're stressed, because you're not sleeping at night, also impact overall calorie intake, right? And having the hard conversation that calories in, calories out are the king of everything, no matter what. Like there are external factors that make things much more difficult for you to stay in a deficit, but nothing's broken with that. Nothing's broken with that. So that's
I
a hard one that a lot of women come in, but once we have that conversation, they understand that, even if it takes 5 months or so to kind of move past that.
5 months. You're doing well. You're doing better than most. I always find it funny that there's still people parading around telling me that I had a girl yesterday, she's a pretty good coach who I respect, and she got on an Instagram live and started talking about how calories in, calories out is bullshit. And I said, okay, if calories in and calories out is bullshit, then why is it that the law of thermodynamics has never been disproven? And why is it still one of the only things in physics that actually makes any marginal amount of sense? Now, is it practical to just drop somebody down to the basement and just underfeed them chronically to get them to lose weight? No. But argument still stands. If you drop somebody's calories low enough, I don't give a shit how fat loss resistant or metabolically dysfunctional they are. They're going to lose weight. We have plenty of evidence to suggest that constantly. But when you're talking about improving the function of the metabolism, how can we set realistic standards and expectations on how long this process is really going to take? Because it's a lengthy process.
Yeah. I mean, it depends on where they're coming from. Like, do they have any experience? And are they coming off of yo-yo dieting for how many years? Am I seeing a 72-year-old? Am I seeing a 45-year-old? So that all depends. And then it also depends.
I have a question because we talked about the broken metabolism. These metabolisms aren't broken, but then a couple times now you've referred to the yo-yo dieting. If somebody has a history of that, explain how that has this maybe effect on their metabolism, because that's what it sounds like. Somebody who has this history of yo-yo dieting, lower muscle mass potentially, for people to understand that.
So I'll say this in two parts. Yo-yo dieting specifically relating to they put themselves in a calorie deficit. One, it could be that it's so low they can't maintain that. But two, it could be so low where now their body is not able to function, meaning from like a fatigue standpoint. They just don't have the energy to do things at the gym, where now they're bringing less intensity to the gym to actually rebuild muscle or to see any changes happen over time with that. So I think yo-yo dieting takes a few different terms from that standpoint. But are there people that come in, and this is kind of just circling back, but are there people that come in and have chronically been doing like a 1,200 calorie diet for 5 months and they're like, I'm not losing weight, I don't understand? Well, first, are you actually doing a 1,200 calorie diet, right? That's the first conversation to have. Is it possible that somebody can come in and they are at a 1,200 calorie, I'm going to say this with a straight face, are they at a 1,200 calorie diet Sunday through Friday? And then Saturday, they're at a 4,000 calorie diet. That's likely what we're seeing with that.
That's the fun one.
Yeah.
That's a ROMS program. And
But I also have the fortunate ability to function on 4,000 calories.
Yes.
I'm Sunday through Tuesday and then Thursday through Thursday evening in my deficit. That's why I've been successful.
But also unlearning like the idea of a cheat meal, right? And I do, on a very serious note, I do have quite a few patients who have eating disorders, and it's the full spectrum. And a lot of that is related to these cheat days, right? Or these cheat meals, because they turn into days and then they go in over restrict during the week too. So
yeah,
it's a
we're
double
not fans. Yeah, we're not fans of the phrase cheat meal, because if it's allowed, it's not cheating. It's like, it's like a scheduled high calorie meal or a refeed meal. Even that, I think, sometimes can change someone's perspective.
I like the idea of planned indulgence.
Yeah.
Yeah. Yeah.
Intentional indulgence, whatever it is. And I think whether it's an eating disorder provoked reaction, or whether it's somebody that's still hanging on to that idea that I can be good versus bad.
That's a conversation we have all of the time.
Yeah, we have to remove that morality and remove the power that food tends to have on people.
The shiny substance that surrounds that food, right? Like you're doing it to yourself. So have it with lunch and then tell me how you feel. Oh shit, now I don't feel like having it all the time. Okay, great. Now let's move on from that. But having that we're spending 3 months working on that. And they're like, well, I'm not seeing any changes in my weight. Okay, but now let's look 12 months down the road. Now you're not overindulging in whatever this shiny object, or meal or snack was. You are going to make changes. It is patience with this, but you have to do the unsexy work first, right?
I'm very upset we haven't found you earlier. You're like my spirit animal.
What when people come to you, do they have any idea what they're getting into? Are they like, all right, I'm struggling with my weight, I heard good things about those places. Do they have any idea what they're getting into? If not, when they get in there, what are they expected compared to what you're doing?
Yeah. Well, I have changed my tune, and I require people to pay for their first appointment. So I don't take insurance. So you have to be dedicated, right? Like you're going to pay for an appointment and you pay for a monthly subscription with my office. But that means you get access to me 24 hours a day. So you have an issue, you text me. You have a question, hey, I'm going out to eat, I don't really know how to prepare for this. You text me, right? Questions on blood work, whatever. So the first step is, are you ready to commit by paying for your appointment? And if you cancel outside of 12 hours, you don't get that back, right? So that was the first thing that I was like, when people are ready, they'll pay. But when they walk in the door, I'm joking with you guys, but it really is like, hey, let's acknowledge that this shit has been hard, right? It is hard when you feel like you're stuck in a rut. I do have the conversation of, how long has this been happening? Has this been a childhood thing? Is this something related to trauma that's happened in your life? We get into the nitty gritty right off the bat with this. Tell me why you are here. And that is to have them actually verbalize.
Do a lot of them know?
With my weight.
Do a lot of them know or acknowledge? Because I've had an experience where people didn't understand why, and then after working with them for a while, they're like, Jesus, I just kind of figured out this shit.
So let me take that back. They acknowledge that they are struggling with their weight, but also I think that first step comes from, this is strictly an obesity medicine practice. That's all I specialize in. So to make that first appointment, they have to be at that point where I identify that there's an issue, number one, right?
Yeah. Do a lot of them recognize, hey, this is a childhood thing when you ask them that? Do they go, yeah? Do they realize that? Or are they like, I don't know?
Nobody's, for a majority of people, nobody's asked them the questions.
Yeah, that's what I'm saying. Like, do they have an answer? Or are they just like, I don't know? And then they do figure it out later. I'm just curious.
Yeah.
When people are confronted with that question.
I've had a mix. I've had some people actually sit here and box of tissues are here and they're like, oh my God, I realized that my dad would slam his hands on the kitchen table and that would give me a negative reaction with dinner. And then my mom would take me to go and have ice cream, and that felt really great. And 30 plus years later, they're binge eating ice cream. Well, okay. But then I have people who will be with me, I don't know, we'll say 3 to 4 months in maybe, and they'll come back and they'll say, that was really thought provoking. Like nobody asked me that question and I never thought about it that way. And that makes a shit ton of sense. And I'm like, all right, cool. So we're getting somewhere. So that is one of my favorite parts to see is that light bulb go off.
Yeah.
It's interesting to see a clinician like yourself who's taking like a partial tough love, partial empathetic approach, because I think that really is the only way to do it. Because there's only so much empathy that you can deliver before it becomes enabling, and before it's like. And I think right now we're just in a time where the body positivity movement and healthy at any size at all sizes. It's certainly not bad messaging to be able to provide and to give people some reprieve away from focusing on things like scale, weight, or body composition. But there are health ramifications that we do need to consider. And I think that's the hard part is, when do you decide as an individual that you finally hit rock bottom and this is no longer just an aesthetic problem that bothers you, that this is going to impact your quality of life, your health, your longevity, your ability to show up in the world? So when you're starting to have these conversations with people, how do you get them to steer away from the aesthetic part and the kind of that personal hatred for themselves and that aesthetic desperation, and move them into like how this is going to contribute to their positive quality of life?
Yeah. I will say it's all that a lot of people know when they come in, right? Like my goal is to be X amount of weight, but I don't ever ask that question specifically. I don't ever say, what is your goal weight that you want to be? Because I think that sets up that thought process, right? How I explain this is, what are some things that you want to do? What's your why for being here? Don't give me anything associated with your numbers. What is your why? I want to be around for my grandkids. My dad died of a heart attack when he was 60. I don't want to be able, I don't want to do that. So it changes that conversation to more touchable things versus a weight. And the other thing is really putting a lot of emphasis on, I'm not trying to get people into a normal BMI, right? Like we know BMI is outdated. We know that. We are looking at this from a body composition standpoint. And I put a lot of emphasis on that. You get a free body scan, though it's not, we can talk about logistics of that, but you get a free body composition scan if you're a patient of mine. Go and do it. Let's see what's actually happening inside. But we spend a lot of time talking about visceral fat. We spend a lot of time talking about what percentage of body fat looks like on the outside versus what it would look like on a scale. So how your body shape changes when you strength train versus what you would do if you are just dieting and not changing what you're doing on a day-to-day basis, right? But then also I do more blood work than most primary care doctors do. It's not a dig at primary care doctors. I think it's specifically just related to they're overworked and they don't have a lot of time. And I think
plus insurance, and even insurance, it's like we're not paying for it unless there's symptoms. And then most people don't even know what low symptoms are of certain issues. And then they just don't get it checked. And they're like, it's not a concern until it's concerned. Well, I want to find out because I want to be preventative. Right. We don't do prevention.
Yeah. So going off of that, right? Like insulin levels to tell us, do you have insulin resistance present? And I explain this to people. If this comes back and insulin resistance is present, it doesn't mean you can't lose weight. It just means there might be factors that make it a little bit more difficult to stay in a deficit that contribute to weight gain, weight loss, maintenance, whatever. But also doing risks for blood work for cardiovascular disease outside of a lipid panel, right? Like you have specific proteins that are carried on your cholesterol that give me an idea of how likely are you to have sticky plaque develop within your arteries. Okay, if you had a grandfather or your father died when he was 60, I'm going to run that. And if that comes back high, we have to really talk about that.
Is that the lipoprotein A's and B's? Yeah.
Yep. And it's shocking how many people don't know about that unless they're being followed by cardiology. But if you've never had symptoms and you're not established with a cardiologist, you're not going to know to ask for that, and nobody's going to be drawing it for you. So it's giving people the whole picture of what's happening. Even if, you have insulin resistance, you don't necessarily have prediabetes, you don't necessarily have type 2 diabetes, but if nothing changes, you're likely to develop those things, right? So how do we stop this and change where you're going?
Well, and I also think too, like when you start talking about insulin resistance, it becomes this, almost this pursuit to just eliminate all carbohydrate intake when in reality it's not. I don't think the common person is viewing carbohydrates as fruits, vegetables,
No.
and potatoes and rice. They're viewing carbohydrates as cookies, chips, crackers, and bullshit.
Right.
And those are not just carbohydrate sources. Those are carbohydrate sources that are coming with a significant amount of fat calories
It's
attached to
this
them as well.
Aram. It's the seed oils that are in those foods.
Yeah.
Don't
Yeah.
even
It's
get me
not.
started.
No,
It's about the ingredients, Aram. It's about
yeah.
the inflammatory seed oil.
Oh,
I have,
okay. So Jenna,
yeah.
let's talk about that because the word inflammation makes me want to fucking vomit. Also,
That's because of his It's because of his
Unless you have
cortisol
like
face.
high LP little a, then we can talk, that would give me concern for inflammation. But anything else outside of that, I mean, CRP, yes.
I was going to say, is CRP a concern for you or no?
I draw that for people. What's interesting though is while we're on the topic, I do have one patient who she has lost significant weight. She is down 80 pounds overall.
Wow.
But her CRP isn't reflecting her weight loss. So
Meaning
we're
it's still high.
so it's been fluctuating. So she's been high. It was on a downward trend and then it shot back up. And we're trying to figure out something is clearly wrong. But why is this going the opposite direction when you're losing weight? So is this something related to, do you have an undiagnosed autoimmune disease, right? Like when we did blood work, thyroid looked great. There's no issues with that we can see. We tested for the celiac gene. She doesn't carry it. So that's not an issue that she can have. But could she have gluten intolerance not related to celiac? That's potential. But, is there anything else going on? Like, could you
Digestive
develop,
health.
yeah, like is there IBS or is there Crohn's disease or something that maybe you're not realizing the symptoms that you're having is actually related to one of those things. So that was just interesting to me because usually I will see when people lose weight, the CRP will come down too. The other thing I've noticed is homocysteine levels as well.
I was going to say,
where we could talk
what
about
what are the best markers for folks to take a look at, or at least be able to ask for to draw when they're concerned about inflammation? Because I think and also too, if you wouldn't mind just explaining the difference between somebody who's experiencing real pathological inflammation versus I'm just a little bit belly distended because I had a shit meal.
Yeah. So when I think of inflammation or I have somebody sitting in front of me with inflammation, this could specifically be like irritation within arteries inflammation, but this could also be rheumatoid arthritis, lupus, Crohn's disease can cause inflammation overall. Inflammation overall meaning, do you have fluid being stored outside of where it should be, number one, or excess water retention that's happening? I mean, you could even say this if you have chronic kidney disease too. But if you're looking at this from a standpoint, I hate to keep coming back to the body composition scans, but you could even trend water retention on that too to kind of identify what does that look like? Do I actually have water retention happening? But outside of that, I would say homocysteine level, a C-reactive protein is very helpful too. And then looking at your hydration status as well and all of your everyday living changes, right? Like, are you having bowel movements once a day? If you're
Like
not,
you looking at like potassium, sodium levels and stuff like. Okay.
yeah.
And then you were saying the LP, small a, small b.
Yep.
Are those going to be markers for cardiovascular inflammation?
Yeah, so
Okay.
LP little a will give you a better idea about cardiovascular inflammation. APOB gives you a better idea of cardiovascular risk. So it doesn't say, you are going to have a heart attack. This is going to give you a range based on those numbers, and it will say how likely are you to develop cardiovascular disease. LP little a gives us an idea of inflammation, the materials that's carried that are likely to develop plaque over time, and the inflammation that's in your arteries. So those are two different blood tests that we can look at.
And then obviously, since you're doing blood work, and because I work with mostly women that are entering perimenopause or in menopause, there's a pretty prevailing narrative that says obviously when hormones decline, weight loss resistance starts to begin. And I just want to talk about, whether it's thyroid dysfunction or sex hormone dysfunction, what can somebody expect as far as difficulties when those things start to occur, and how can they combat those difficulties?
Strictly related to like perimenopause or menopause. Is that what you mean?
Yeah, or just any type of like thyroid or oral sex hormone dysfunction, and how it relates to the inability or the ability to lose fat.
Yeah. That is another hot topic right now too. Again, coming back to calories in, calories out, right? Like that's going to be the standpoint from this for sure. I think people lose track of, as your body composition changes over time, maybe an injury happened because you're more likely to get injured. Maybe your intensity to the gym changes, so you're losing muscle mass more so than you thought. There is a lot of true fat that does establish around your abdomen. That I'm not going to negate. But I think from my education and what I'm reading is it's more difficult to stay in a deficit as you go through menopause because of cravings that will start to come in because of blood sugar regulation, right? So it's, how do I say this? It's not necessarily that menopause or perimenopause is causing weight gain specifically. It's a secondary effect of something else that's happening. Does that make sense?
Absolutely. And I'm getting into like these battles with these 3 to 500,000 follower.
It's not to say it doesn't suck. I'm going to go through it
Yeah,
at some point, and
yeah.
I am fully expecting hell. But
Well, and I just think that it's disempowering to women to tell them that you're fucked or you're broken, as
yeah,
opposed to, hey, this is the fact. It's going to be more challenging, so I'm setting your expectations up properly.
right,
But it doesn't make you unable to do
right,
any of this stuff. Like you're completely capable of still eating well. You're
right.
capable of improving
It
your
might be
sleep.
harder. It
Sure.
might be harder, right? And
No.
acknowledging that, but also the fact that it's being talked about and saying, because this wasn't talked about for so long, right?
No.
But also having this plan to say, hey, we have plans for when you have your first period as a female. We have plans for when you're pregnant. We have plans for postpartum. Now we have a plan for menopause. So you carry that through, right? Here's your template. It doesn't mean it's going to be easy. It's going to be really effing hard, probably. But if you can go in with the education and say, how can I best reach these goals, at least you have something to go off of and you have a support team and you can figure out where is my weak spot. For a lot of people, generationally, does that mean it's therapy? It really could be. And I'm not saying that to be a jerk. I'm really saying a lot of that relationship, the emotional relationship with food, does come into play, or alcohol, right?
Yeah. I did want to ask about the therapy thing, but first with, because that was one of the early things you said when people come in, I'll recommend therapy. So I was curious, like what maybe red flags were for that. But I wanted to at first ask with the menopausal response of maybe increased cravings, making the calorie deficit harder to maintain. Is this then where it's a good place to use the GLP-1s or any of the weight loss? Because that's what you do in your practice, right?
Mm-hmm.
So tell us about that, when those are coming in, if there's people that come to you and it's like, no, we're not going to use these and here's why you're a good candidate. Here's what I want to see before we use it. Here's the plan and the strategy, et cetera.
Yeah. So for the initial appointment, it takes 60 minutes. So we go through everything. Like, what does your food log look like? What do your structured meals look like? Are there structured meals there? Emotional reactions or emotional, anxiety, depression, like diagnoses that are associated with this. So we go through the whole thing to say, give me a baseline. What am I looking at? What's this picture here, right? Blood work comes into that, yes, but also medications that people are on too. If somebody comes in and they are like, listen, I am really depressed. I can't get to the gym because my joints really hurt. I don't feel like I can make changes. I feel like I'm banging my head against the wall. I have been dieting for 40 years and I'm not making a change. Okay. I think to myself, I can sit here and be like every other person that has said, oh, you have to change it because you have to eat less and move more. Or I can say, do I have a tool for you that's going to change your perspective a little bit and allow you to stay into a calorie deficit? That's number one. Number two, why couldn't you stay into a calorie deficit before? Like, why couldn't you stay below that? And for a lot of people, it was emotional things that were happening and they were eating as a cause of that. But it's now become more difficult for them to stay in a deficit because of the emotional eating related to that. So I say, let's start this. That doesn't mean the other things are not important, but it's to stop the weight gain.
And the
It's
food
to get you
noise
moving
potentially
because
as
that's going
well.
to be able to bring your depression and control your depression. And it's also going to be able to bring you and kind of ground you a little bit to say, hey, we have to put a pause between the emotional eating, even if that means there's a medication or a signal that's going to say you're full stop eating. Or if you go and have foods that are high in fat or fried foods, you're going to have a visceral reaction to having those. This is kind of like I don't want to call it a reset because it's not. This is your bodies are not hearing these signals. How do I get you to hear that? So this is, when people come in, there's a lot that it's not like, okay, here you go, I'll see you in 4 weeks. Like everybody gets a script, woohoo. It's, what do you actually know? Like, do you know what a protein is? Do you know what a carb is? There are people, very few that come into my office, but that have never dieted, that have never tried anything. And that's one of the questions I ask, like, what are the diets that you have done in the past? And the laundry list for many people looks like a CVS receipt, truly. But then there are some people who are like, I never had an issue until right now. Okay, well, here's education. We talk about what it looks like, body composition, calorie deficit, all of the things. Let's try this first. Let's try a meal plan. Let's try, do we do macros? Do we just talk about what your plate should be looking like? Do we talk about feeling fullness? Do we talk about, leptin and ghrelin and all of those things first? And then from there, it also comes into what risks do you have associated with cardiovascular disease, any other comorbidities? What are we looking at as a spectrum, and where is your starting BMI? So in that standpoint, again, we know that BMI is, I say outdated, but I really mean percentage of body fat. That's what I mean when I say BMI, right? Like, where are we falling in that? And
plus, for the average person who does not weight train, BMI can be of value. But for the person who's weight training, BMI is not of great value.
I mean, and you can still have a normal BMI and your percentage body fat can be very high.
Correct.
Right?
Yeah. Yeah.
Well, skinny fat is your classic example of that.
I'm considered overweight / obese. You're probably morbidly obese in terms
I'm morbid.
of BMI.
I'm morbidly
You're morbid,
obese.
right? Yeah.
Yeah. I'm 5'8", 220 pounds almost.
Yeah.
And I'm morbidly.
Yeah. Yeah. I'm just regular obese.
I'm on my way out already. We already know that. I think it's fascinating.
It's the cortisol phase. If we can get the cortisol phase.
I'm going to get so much shit for that, but I had to say it.
No, you're not.
We
You're
love
not
it.
Not from this community. This community is very supportive of the anti-bullshit campaign. So
yeah.
I think it's a relevant conversation. I'm glad you brought it up. Do you subscribe to the concept of leptin resistance at all?
Ooh.
Obviously, probably case by case, but I spent some time going through Stefan Guillenet's Hungry Brain book, and I think it's a wonderful read for anybody who's having any type of psychological eating issues, because a lot of that, I think most of it's rooted in that anyway.
Yeah, I think it depends on how far, again, like you said, it's person by person, but I think it depends on what other aspects is it impacting overall. Like, is this controlling every aspect of your life where you can't get out of your own way and you can't find another healthy habit to start to change the trajectory of where you're going with your life, right? And it sounds easy for me to say, and this is also a very real conversation I have with patients too. Like, I am sitting here from a standpoint, I do not have anxiety. I do not have depression. I am very proud of myself to say that. It doesn't mean that if you are dealing with that, you're weak or you've done something wrong or anything, but it also means that things that I find to be just easy tasks to do might not be the same for the patient on the other side, right? So if there's one way that we can figure out what's an easy task for us to change the trajectory of weight gain or anxiety or depression, what's the easiest thing we can do? Can I give you something to literally print out, put on your refrigerator to make sure your meals are structured, adjust high fiber, get protein in, get some well-rounded meals to control blood sugars at least, start with that, right? Like, very hold your hand through this process. But continue. I didn't mean to cut you off.
No, I think that's all, because at the end of the day, it's not hard to pinpoint any of these problems. If we're talking about just the mechanisms of action that make any of these things work, it all comes back down to the basic boring shit that people just haven't adopted as a lifestyle or a routine yet.
Right.
And it's really, like you just said, protein, fiber, getting enough movement, getting enough sleep, not drinking like an asshole and managing your stress. It all sounds on the surface to be so simple,
Right.
but the complicated part isn't knowing what to do, it's doing it. And that's really a more of a psychological deficiency than anything else. But I think I'm a massive, I used to, when GLP-1s became popular, I was kind of the
So
camp that I wasn't in support of them. But as I've learned more and more about the mechanism of action, what they actually do, I'm the biggest supporter of them on the planet. And I think there's plenty of use cases in which they make all the sense in the world.
Mhm.
And one of the best use cases, and I want you to discuss this, is that food noise aspect of it. Because if you're somebody who's sitting there obsessively thinking about food and we can shut that down or quiet that noise, we've just bought back a hell of a lot of quality of life that you didn't have before.
can you send me a 6-week sample of a low dose, so I can have just just to be able to provide a testimony to your services? Just a 6-week.
Just a
I have
little
a thing.
tirzepatide. Just
I
a
don't get
little.
enough samples to do 6 weeks. Sorry.
That's fine. You could pay for it. It's fine. Just send it. I'll send.
I'm not in the right field to be able to pay for that out of pocket. So
Fine. I'll give you $50 to cover the shipping. Whatever helps. I just want to. We at Aram want to really be able to be frontline warriors for this and discuss how beneficial it can be.
I would love. I mean, I've experimented with so much shit in my life. I would love to experiment with GLP-1s because I'm so
I'm
curious to see what they would do to my.
According to like Western medicine, your BMI would qualify you. So
Me too.
I could probably go get a script for it.
you could.
And what's that running on average for somebody to go to for this stuff? What are people paying?
It depends on if insurance is covered. If your insurance covers these medications, it could be anywhere from $0 to $25. If it's not covered, you could be looking at $350 to $499 a month.
Okay.
I mean, are we talking about the compounded versions too? Because that stuff you go to a place that's selling compounded meds, they could easily be charging you $800 a month.
Why is the compounded more expensive? Just the process of it?
Oh, I'm going to get a lot of shit for this too. No. So it's a service.
Okay. Yeah. Okay. No, I mean, the reason why I ask is because I being in the field that I'm in, I'm connected to a lot of people who own wellness clinics or HRT clinics or med spas, and it's much easier to access those things.
Yeah, I do not disagree with that, and it is a moral dilemma that I face where if I have somebody who qualifies and I spend many hours fighting insurance, and for them to come back and be like, sorry, like we're not going to pay for it. Somebody who's not in the medical field, comes back and tells me that my judgment is wrong. Am I a gatekeeper to say, I can't get this for you? Like you're SOL, this is another 40 years of you struggling with this. Or do I have a very realistic conversation with them to say, listen, I can't prove to you that these are as effective as the FDA approved medications because there's not a sticker on the jar. However, if you want to sign this consent and you know that this is not FDA approved and there's no research to show you what's going to happen in 10 years with this, here you go, right? Here is this. You still get the same education. You still get all of the same knowledge from me as if somebody who's on the FDA approved stuff. But it's really unfortunate how expensive they have made it. And it would really be life-changing for a lot of people who have Medicare and Medicaid to be able to at least have access to this.
Is it just a supply and demand issue at this point?
No, this is monetary. Like it's too expensive, and insurance they won't cover Medicare and Medicaid at
As
all.
long as people are still buying it, it's going to stay that expensive.
Yep, they're not going
as soon as all of a sudden people are like, fuck this, I'm not paying this much. And all of a sudden, all right, fine, we'll make it cheaper.
But again, you find something that works.
Yeah, it's in demand. People are going to pay for it.
Well, I mean, at the end of the day, GLP-1s are peptides, right? They're categorized as peptides. So a peptide is essentially unregulated. You can go onto a peptide website tomorrow and buy BPC 157 and CJC whatever you want. And who's to say that a lot of these things don't work? If they have the chemical composition to do what they have to do, they're going to do what they need to do.
Yeah. It comes down to like the sterile process, and you can read all about the compounding pharmacies and how safe they are. And do you really know? Anything could happen at any lab, right? Or pharmacy or compounding place, or manufacturing plant with Lilly or whoever, right? Like
Yeah.
we've seen this happen with food supply, right? So it's a hard situation to be in, what works, and you're at the point where you're like, this could be a hell of a lot cheaper for you to get. Do you get it? I leave
Could you
that
just
up to
force them to go get diabetes so that they do qualify for insurance? And you're like, listen, we're gonna push the limits. We're gonna eat
500
cake,
grams of carbs.
exclusively
insurance comes
cake for
back
the
and
next
says,
month.
sorry, they're not sick enough. They got to gain 20 more pounds. I'm like, they have severe sleep apnea. They've had a heart attack. What else do you want them to go
20
through?
pounds of fat. That's what we need.
Hey,
And then you go, all right, let's do it.
We're going on the
adjust
Burger
their
King
height a little
cookie.
bit so their BMI is altered. No, I'm just kidding.
Yeah, no, I think that sounds like a great
I
strategy.
would-
For somebody
I-
like me or Aram, so a professional like you would never do that.
Never.
There's definitely going to be video of this podcast as well.
But remember, Jenna, you're under no danger here because we only have 3 listeners and only 4 people look at the videos
Yeah.
anyway. So you're absolutely fine.
Yeah, we'll change your name.
Bread, if I'm in jail, bring me bread, but it has to be sourdough because it tastes the best, freshly baked. So just
Got it. I actually have a sourdough girl in Denver. She's one of my former clients. She bakes
Yeah.
for everybody, so we'll hook you
We're
up.
gonna,
Can you talk about the varying drugs that exist, kind of the more common ones, and then what the typical dosages are? Just because I think sometimes when people are hearing this secondhand from friends, and obviously, I'm sure you know this from being a practitioner, you'll give somebody a protocol, and then they're going to go run out to all their friends and tell them, I'm on this thing and I'm taking 500 milligrams, and they have no fucking clue what
and
they're
they'll say
talking
they're
about.
taking a low dose, but it's not a low dose.
Yeah.
Right. So I want to dispel some of these things, because even something like TRT, which I'm on, I ask people all the time, I'm like, what dosage is your doctor providing? And they're like, oh, I don't know, 2 cc's. I'm like, that's the vial. I don't need the cc's. Give me
I
the
need the
milligrams.
milligrams.
Give me the milligrams. Oh, I don't fucking know. So you're just
Yeah.
sticking yourself with a needle. You have no idea what's in it.
Yeah.
That's not a good way to work. So I want to just kind of talk about that, because I think it's going to help clarify what should happen.
Yeah. So I'll give you a little bit of breakdown. So there are oral medications too, which they don't get any attention because they've been around for forever and nobody talks about them, but we'll talk about those too. So you have Wegovy and Ozempic. Ozempic's been around for the longest. Actually, prior to that was Saxenda. Saxenda was a once a day injection.
Yep.
That no longer is being produced as brand name Saxenda. It's liraglutide now. So that is still a once a day, but everybody moved away from that because nobody wants to inject themselves once a day.
Right.
Victoza is the equivalent of that. That's been around for a while too. So that was for type 2 diabetes specifically. And then Saxenda came out for weight management related to that. But the more common ones are going to be your things like Ozempic, Wegovy, Mounjaro, and Zepbound. So as a prescriber, there are 2 ways to be prescribing them. We'll talk from an insurance standpoint for coverage. There's metabolic disease management, and then there's weight management. If you are trying to cover this for weight management, which less insurances cover, you are going to be picking something like Wegovy or Zepbound. If you are doing this from a standpoint of diabetes or a metabolic disease standpoint, it would be Ozempic or Mounjaro. Ozempic and Wegovy are the exact same medication. Zepbound and Mounjaro are the exact same medication. They do the same things. So when people are saying like Ozempic is for people who have diabetes, well, they're all the same. They're equivalent, right? So specifically with Wegovy, 0.25, 0.5, 1 milligram, 1.7, 2.4. That's
Wow,
for Wegovy
okay.
specifically. Now, how insurance kind of butts their head in with this is they dictate what the maintenance doses are. So
Okay.
I have to go back and, just because there's a max dose doesn't mean a patient needs to be on a max dose of anything. So every 4 weeks or sooner if patients need that, we talk about how are you feeling on the medication? What side effects are you having? If you're having side effects, we're not moving up. That means there is something in your everyday life that we have to change. Your volume is too big. You're not drinking enough water. So this really forces people to look at their lifestyle changes and pay attention to them because you're having a visceral reaction. But the ways that some providers prescribe this is 4 weeks, okay, we're going up. 4 weeks, okay, we're going up. But that does nothing to help them. It doesn't force them to change anything. So specifically looking at that, it's volume, it's how much how quickly you're eating, and then types of foods that you're eating. That's going to elicit a side effect for you, right? So peeling apart all of that, then it would be if you feel okay, you've changed these things, maybe food noise is still there, which we'll talk about. I didn't forget your question. Then we go up if we need to. But I have a handful of people who don't necessarily have to go up past the first or second dose, yet they are looking at the maintenance dose that you have to get to as the 1.7, there's 2.4. That's a lot of steps to get to that.
That's considered a maintenance dose?
Yeah.
And that's essentially the highest prescribable dose there is.
Yep. But when Zepbound came out, they adjusted that. They have much lower doses that are considered maintenance doses. So they learned from that and are like, well, shit, if we can get more people on lower doses, that's going to work in our favor, which it has. But that's something that I have to fight the insurance companies with and say, like they're losing X percent of weight, which you also have to prove that it's effective for them.
Sure.
Everything else is working. They're making lifestyle changes. They don't need to go up to a higher dose if they don't need to. So then every month it's a fight to get the next one approved so they don't have to move up. But that is one of the faults of many with insurance companies is that they really try to force patients up. And if you have a provider that's not going to fight for you at the lowest, most effective dose for you, you're going to be forced up higher.
So, and that's driven by the insurance company driving that number up. Mm-hmm. Interesting. And now
isn't the client, the customer, the patient, they're the ones injecting themselves?
They're injecting, but it's the provider
Couldn't you say, yeah, you have to go up a dose, but we're not really going to go up a dose?
Well, no, because it's a one-use pen.
Yeah, it's a pen. Man. Yeah. Zepbound's a one-use pen, right?
Never mind.
So you take Wegovy and Zepbound and Mounjaro are one-use pens, so you get 4 in a box. If you were on something like Ozempic, it's a multi-use pen, so you have more control.
Okay.
Saxenda was the same thing. You had more control over your dose. So as much as people don't like injecting themselves every day, you have better control as the person who's in maintenance to be able to say, oh, I don't feel like I need to go up any higher than this. I'm good here. And then you get to extend out how much of that medication you have in reserve because you don't need to use it as fast as insurance thinks you're using it, right? But yeah, that's Wegovy from that standpoint. Zepbound is 2.5, 5 milligrams, 7.5, 10, and 12.5, and then it goes up to 15 max. So Zepbound took a different approach. Mounjaro works the same way, same doses. 2.5 is the titration dose, meaning you do 4 weeks at that, and then you go up to 5 milligrams. 5 milligrams is the first maintenance dose. You do not have to go higher than that. But if
you're experiencing a result, you can stay there.
Yeah. But even people who are on the 2.5 that are super responders to the medication, like they're very sensitive to it, food noise is gone. 20 pounds gone over, I would say probably 3 months. Yeah. I am not fighting for them. They are staying on the 2.5. You do not need to go higher. Like we have figured this out. I will fight every freaking month if I have to get you to stay on that. Why would we go up to the 5? No need to. So there's a lack of clinical acknowledgement with how these doses actually work and affect the patients. And it's more so how many more people can we get on the drugs? That's what they're trying to do.
And is this just a scam that insurance would be like, no, it has to go up, that they're getting kickbacks? Like, what do they care?
They want, does it come back to a supply issue where
I'm saying it's like they're going to try to force people to take more of a medication with the provider saying, no, they're good here. You have to fight to keep them there. It has to be kickback. Like this stuff makes no sense to me that insurance is going to say, no, you need to give them more of this medication that we're paying that company for, that the CEO of that company used to work for the FDA. The FDA guy here used to work for that company. It's such a scam. So send me 4-pack of the single. I'm struggling, Doc. I'm struggling.
Listen, I already put myself in jail. I can't make it any worse at this point. So
I'm gonna eat a whole tray of brownies tonight unless you do something for me.
He's gonna emotionally binge eat tonight just to prove a point.
I have a new patient appointment open next week. You can sign up and then you can phone me and
Is
then
it
we'll
virtual?
talk about it.
It'll be virtual. It's only $800 for the consultation.
Yes.
For the first consultation. All right, sounds good. I do appreciate you doing that for free for us and all the people that listen to this, as just a way for us to give back to you.
Yeah,
With getting you new clients.
discount code.
We're gonna get
Jenna.
you new clients because of this, new virtual clients. So for you to offer the first consultation free for me and all the listeners,
do you do telehealth or no?
Yeah.
You do. Okay.
Everybody
so
does.
I'm only licensed in New York though, so.
All right. So if I call from a New York number, is that? If I call from a New York number, if I get like a New York cell phone?
No, she can't ship drugs out of state, dipshit.
I can't technically be your provider because it's where you're located, not where I'm located.
But if I have a P.O. box in New York.
What I don't know.
There you go. See, there's always a way around it, Aram. Aram knows somebody at every state. He's got it. He has an address in every state in this country.
Listen, I still get my TRT delivered from somebody in Vegas, and not the pharmaceutical company.
I like how the TRT is the word that was in quotes. Like that's the.
Well, it's no longer testosterone replacement therapy when it doesn't come with a prescription.
Oh, okay.
It could be a TRT dose.
I thought you were
currently is.
Okay,
but
I'm thinking.
But my prescription from my urologist has lapsed. I have not renewed it, and now I just buy 10 milliliter vials of testosterone cypionate from who I need to buy it from for half the price that lasts me twice as long.
Yeah.
And I'm all set that way. And but here's the problem. That right there is the biggest issue. Is like I can get my treat, and I'm doing it from a clinical standpoint where I need the treatment because I know how my body reacts when I'm not on it. But I'm almost being forced to have to go underground to do it because it's such a fucking pain in the ass to be able to schedule the appointment, to have to go get seen and go through all this red tape to get the thing I need to keep getting, as opposed to just making that red tape disappear and allowing people access to these things who actually medically viably need them. Mm-hmm. And that's what bothers me about it is some fucking asshole from Montauk can drive up to a med spa tomorrow with $1,000 in cash and buy as much of this shit as they want, but then fucking Susan, who's 375 pounds, who's on Medicare, is going to slowly die because she can't get it, because she can't afford it, because they're going to make her jump through hoops to get it. Mm-hmm. And that's where I think it's so nice to be able to see folks like you who are actually trying to get this stuff to the right people in the right hands, doing it the right way, as opposed to the drug getting this bad stigma and it's cheating and all this other bullshit. It's not cheating when it can be the thing that saves your life. It's no more cheating than hormone replacement therapy. Yeah. Now, when people
it's not cheating. You're not in a competition that doesn't allow it. It's not cheating. Like being on testosterone is not cheating. You're not in the fucking MLB.
Yeah.
Well, and cheating. Also too, do people eventually get off of the drug? Can they titrate off, or is it something they're going to have to maintain, like hormone replacement therapy?
So this. It's per person. Again, I hate saying that's how it is, but it really is. Yeah. If you have a metabolic disease, if you have type 2 diabetes, depending on how bad your prediabetes is and other comorbidities that you have with that, it's much, much, much more difficult to get somebody off of Mounjaro or Ozempic with those things present. Depending on where people are starting, so morbid obesity versus being overweight, right?
Sure.
It's much more difficult to get somebody off of these medications when they've lost X amount of weight. And I can't sit here and say it's 30 pounds. I can't sit here and say it's 50 pounds because it does truly matter. A majority of people will have to stay on these medications lifelong or until their insurance is like, we're not covering it anymore. Sorry. Then are they going to go somewhere else? Probably. That is one of the things that I do talk about with patients so that they know. And I think that is where there's a lack of education when you are going to a med spa, that they don't tell you that this is something that's potentially a lifelong investment. Because what does that mean? You have to keep coming back to still get it, right? So instead, they're doing 12-week programs. Yeah, this is great. I can do this for 12 weeks. I can do anything for 12 weeks. Well, what the hell happens when you get to the end of 12 weeks? What have you learned?
What's the aftercare? What habits have been put in place to be able to manage these things?
So that's where very real conversation comes in, and I spend a lot of time in the initial appointment talking about what a maintenance plan looks like, because if you can't visualize that and realize that this is the path that we need to take to get there, we can't start today with what our plan is, right? You have to be all in for the whole journey, or that's not going to happen.
I was going to ask you, are there times where people come in and basically say, hey, doc, I want the drug, and you're like, nope?
Yes. I have. So when I first opened my practice, I did not have a do you qualify form. So I was getting a lot of people who were going on vacations, who like it would have put them in a worse position from a health standpoint, meaning they would have lost muscle mass if I put them on it, because that's how little fat they had to lose.
Right.
And I have to be the one that's like, I know you might not be where you want to be, but that does not mean that this is the right thing for you. Did they go to a med spa and buy it? Probably. But morally, I couldn't do that. I can't do that for somebody. I don't care how much you're going to pay me, but I can't.
Yeah, she's pointing.
Even $120.
Oh my God.
$120.
I can't wait till Jimmy gets skinny fat and just completely destroys any ounce of muscle tissue he has and just walks around like a melted candle all day long.
Dude, it's on. It's on. I'm gonna do it.
I might actually pay for your Ozempic prescription for a year and just tell you not to lift weights, not to eat protein, eat whatever the hell you want, and just get on it. And then we can run the experiment for a year, as compared to the experiment that I do, which is I'm going to keep upping my anabolic dose for that same year, and we'll see who dies first.
If I stick with my regular amount of test and then I add Deca and Wegovy,
that might be the perfect recipe. Right? I actually, and funny enough, Jenna, and this could be something that you can start to specialize in.
Testosterone
and
Ozempic.
Where there's a massive opportunity for Ozempic and all these other drugs is in post bodybuilding competition food noise reduction. I've actually seen a lot of pretty good coaches that I trust and like start actually advising their clients to go and seek it, because their food noise is just so ridiculously high after dieting for 16 weeks. And a lot of, especially female competitors, can put on 20, 30, 40 pounds post-competition. And I'm like, what a perfect bridge drug into getting back to a normal eating.
How many are going to just try to end up staying on and like try to stay that lean? Because we know the mental aspect of gaining even 15 pounds back. Most people are like,
I think that, I mean, there's a time and a place for it, but having that conversation of, again, relationship to food, coming back with that, like, where are we from that standpoint, right? Microdosing, though, these medications is another thing that I have done for various reasons. If somebody is struggling with binge eating, yes, all of the other stuff comes in, therapy and, all the other conversations, but somebody might not necessarily need a full 2.5 dose. So then we go and microdose half of that. And that can be just enough to switch off the food noise.
But you can do that even with the single serve ones, or you're doing that with the other
That's
ones?
A guesstimation. This would be something where you would like order a vial of it, right? Like from Eli Lilly or whatever.
Can you do that? Can you order vials of it as opposed to the preloaded pens? Mm-hmm. Oh, you can.
Can you send it to us so that we can see what it looks like in person?
Is this as a prescriber you can do that, or an end user can actually get it in that form as well?
So you can go to lilly.com and actually order it, but they're going to go through and say, hey, you can pay us for this out of pocket. And I don't know, because usually I just send the script in if they're going through Lilly. And the vial gets sent. But I don't know if you go directly through Lilly, if they ask you BMI, or if they're just like, yeah, here you go, live your dreams. I don't care. It's money in my pocket. I don't know. I would hope they don't. But
so as far as, because I've seen a couple of different things that have been pretty positive effects of the drug. So one use case was lowering any type of compulsive behavior. So people are using it for gambling and alcohol and drug addictions, which I thought was really cool. Mm-hmm. I also saw a reduction in orthopedic pain by the reduction of inflammation, which I thought was cool. Mm-hmm. And then also improving insulin resistance and making people a little bit more insulin sensitive. That's the thing I'm most curious about, because I understand the psychological implications and how those work. But how is it that those drugs are able to make people more insulin sensitive?
Well, if you're
So
taking in
actually,
less.
if you're going to draw an insulin level while somebody is on the medication, their insulin level is actually going to come back higher because they are releasing smaller amounts of insulin over time versus large amounts of insulin at once. So it
Got
does
it.
have to
Okay.
do with the visceral fat that's around the pancreas, but it also has to do with glucose control over time too.
Oh, okay.
Does that make sense?
So is that so really the insulin sensitivity comes from a reduction of visceral fat surrounding the pancreas. So it regulates the release of insulin more steadily as opposed to in spikes.
Right. And because you're controlling glucose levels more effectively too.
Now, is that a function of the drug or is that a function of the eating habits?
Depends. I mean, it depends. Is somebody getting educated about how to change it, or is somebody like
Right.
following, right, just going to pick it up? So you could say
Yeah.
either. I would like, from what I have seen, truthfully, what I have seen is that people have come back and they say, I just don't crave the same things that I used to. Like when I go out to eat, I would normally get a hamburger and fries, but now I'm actually ordering a salad and chicken. And that's not me texting them being like, I know you're going out tonight, you're going to order this, don't fuck it up. It's, I actually feel like I need that. Now, does that come down to, okay, let's think about how these medications work. So they send these signals to the brain that make you feel fuller for a longer period of time, right? They also make the food sit in your stomach for a longer period of time because that weight, the mass in your stomach, continues to send those signals to the brain that will say, hey, you're still full. That's also how this works with the food noise, too. You have these constant signals from the stomach to the brain happening. But there is potential for there to be malabsorption issues if things are sitting in the stomach for a longer period of time. So birth control is one for sure, other medications. But is this something where are you having specific cravings for food because maybe you were so deficient in folate prior to starting this? Now your portion sizes of everything else are getting smaller, and what you were eating, I don't know, one salad once a week before, you cut that out to focus on protein, and now you're not getting any folate in. And now this is the roundabout way for your body to be like, F and feed me a vegetable and a fruit. And then people start to feel that craving, and then that becomes regulation of it. When I order blood work, rarely, I think I've had one person actually deficient in folate, but everybody still functions on a different level of what they actually feel symptomatically from folate. So that's always something that I've been curious about too. Like, yes, it talks to the brain about noise with food, but the specific foods that people are now craving, does that have to do with more of a malabsorption issue because before they even started this, they were deficient?
Yeah, and that comes back to food quality
Right.
and the ability to digest these things and absorb the micronutrients. And that digestive health rabbit hole I think is real deep and real tough. Is that something that you guys deal with as well, or do you stay away from
Yeah.
the gut health stuff?
Yeah. Interestingly enough, I have quite a few patients who have ulcerative colitis or Crohn's disease. And I had to talk to GI doctors, and I'm like, listen, I need to know realistically what this looks like if I'm prescribing this for a patient. And they were like, oh, we prescribe it all the time. It's fine. But from an inflammation standpoint, their flares actually significantly decreased, even on a biologic, which is interesting. They felt great. And from my standpoint, I was like, there's constipation. Like, this is going to be horrible for this patient, as long as their symptoms are well controlled. And what I did was microdose in the beginning for a while until lifestyle changes started to catch up. And then we started to progress with the dosing based on what they needed, obviously. But that was definitely a game changer for that patient. And the dosing that they required and the frequency that they required dropped.
Wow.
Yeah.
There's a lot of compelling stuff to this. And again, the more I learn about it, I'm very excited to see what the next generation of these drugs is going to do. Because from what I understand, the way that they're going to start to branch these compounds is going to start attaching anti-catabolics to them as well, and that's going to be like the gen whatever
Yeah.
next gen is going to be. That's where I think it's now. I've seen some contradicting literature about like the whole muscle loss thing because some says yes, there is muscle loss and it's evident, but that's also because they're not really controlling these experiments for people who don't eat protein and don't
Right.
resistance train. But in the presence of resistance training and in the presence of protein consumption being adequate, is muscle loss an issue? It's
So
not.
I wish I could pull up this in body for you. and this is one of the reasons why, again, like from a female standpoint for these patients to be able to explain this to them, but you have somebody that's working with strength training prior to when they start this medication, it sets them up so much better for success. Building muscle mass too, though. I have so many patients who are able to build above average percentage of muscle mass when they're on these medications. But it does come down to, if you can't tolerate the medication because of dosing issues or whatever, right? You're going to have a decrease in your overall intake, which is
Sure.
going to, bleed into the protein intake, which then is where I see the muscle loss with this. But if you are able to dose up slowly, and this is what people have the hardest time with, is you do not have to do this fast. The faster you lose weight, you're at risk for losing that muscle mass because you're not giving your body enough time or enough calories from a whole standpoint to be able to support what your body needs.
Well, and it also comes back to the conversation that I think people just, even coaches, get this wrong constantly, is the idea that you can't build muscle if you're in a deficit, which is bullshit. As long as protein is equated for, and as long as there's enough
Right.
mechanical tension, you will give your body, especially if people are relatively under detrained, there's no issue building muscle mass in that population. Now, if you have somebody who's got 20 years of lifting experience and they've exhausted their runway,
Right.
and then that person but they have enough internal muscle mass accumulated at that point where if they lose a little, it's not a big deal.
Yeah. I see more of this where if somebody was on a medication and they had a hip replacement, right? Like a significant surgery that's going to change their training pattern over time. That's where I see muscle loss happen. But you would see that even if somebody wasn't on this medication too, right? So
Yeah, it's
I
just
think,
general surgical atrophy that's going to occur because
right,
that tissue is not going to be able to be
right.
active for some period of time.
The overall standpoint from that was, yes, it's a scare tactic. It's very real if you don't have the education and a treatment plan that's actually going along with this. But if you do, it's actually pretty incredible to watch. So I actually partnered with a local gym in the area where we are doing this as a study, where doing in-bodies for patients prior to starting a GLP-1 and then starting the strength training program with their gym and then continuing to work with me. And in a year, what does that look like, over time with their body composition changes? And then also introducing people who have strength trained prior to starting and then going through this, and then people who are not strength training at all. So the in-bodies are just they're really cool to see, especially for people that have struggled so long. And they're like, and they're the ones that are the most frustrated, right? Like, I've been doing all of this shit for how many years and I'm not seeing a change. And it's really cool. But again, this population of people we're going on 5 years working together. So this is not something that happened in 2 years, right? It's been a long time, a long, long time. But a consistent gain in muscle mass and loss in fat mass, it's been really cool.
Good to see that there's some practitioners out there who have a shred of accountability left in them and integrity, doing this the right way.
Because I'm cash pay and I'm not like under the thumb of a huge, system. So, but
Yeah.
I think if we can get quality, I don't think anybody joins healthcare to, screw people over. It's the people who are above them that are trying to account for the money and doing all of this stuff that force you. When I was at this other large facility, my initial appointment with patients was 60 minutes. And I was learning. I was a new nurse practitioner and I was trained under a board certified obesity medicine specialist. And I said, one, I'm new to prescribing anything. I was a nurse before. I didn't have this role. I want to make sure I don't kill somebody by prescribing them a vitamin D. I was so nervous, right? But that's a whole other aspect that you have to learn. So then I got comfortable and I got really good at my position. And they're like, okay, so, initial appointments, we're going to drop to 30 minutes and your follow-ups are going to be 15. I'm like, this is a specialty where people are so vulnerable when they walk in the door because they feel like nobody listens to them. You're going to tell me that I have to spend less time with them? Absolutely not. That was like my last straw. And I didn't know for the first year if I would be out of the red with this practice. I had no idea. Like, would people actually come to see me and trust me? Talk about imposter syndrome. But people like when you have quality to give them and you actually care. And I think that is really why people get into healthcare, but they can't show that. They don't have the time, they don't have the energy because of all the other factors and all the other people above them, which sucks.
We'll send you a QR code that will bring this podcast episode up on their phone right away, and that will boost business big time. We'll
I
send
did
you
not
a
know where you were
poster.
going to go with that. I'm like,
A
oh,
poster
God, you're gonna
size
send this to my old
QR.
boss.
Nah, as seen on Other Side Lifestyle podcasts, people will be like, "Oh shit, that's
Well, I mean,
legit."
essentially, Jenna, what you're doing is you're taking the role of not just a medical professional, you're attaching a coaching environment and a
Yeah,
coaching ecosystem to it. And that's what most of these places are lacking is they're lacking the follow-up, the accountability, and the ability to
the
keep
personal
somebody educated.
relationship.
You know,
Yeah,
it's one thing to be able to prescribe a drug or to read blood work and to do all this shit. It's another thing to actually keep these people engaged in a system that's going to facilitate success long term. And I think if more people adopted your model, we wouldn't be having all these problems that we're seeing.
Yeah.
Did you get, speaking of healthcare, did you guys see the video that the guy put on social media where he got an ambulance bill for
Yeah,
$600
yeah,
for
that
his
was awesome.
daughter, and then he submitted to insurance or whatever. They find out he has insurance, and he gets a bill for $1,300. And it was,
Say I'm surprised, but
if you're not insured, you get a discount. It only costs you $600. If you are insured, we're charging you $2,300. Your insurance pays $1,000, and now you owe $1,300. It's like, it's
Perfect.
insane.
Yeah,
It's insane.
well,
Insurance is insane.
it's been a broken system for a long time. It's not going to get any better ever in our lifetime, I don't think. But at the end of the day, I think as long as, like, we could certainly bitch about all the problems, but I think the problem with bitching about the problems is we don't actually proactively seek solutions or create solutions and opportunities. So to see professionals like you who are doing this the right way, this is what it should be. If you're going to be an NP or a PA or somebody who has the ability to prescribe, do this the right fucking way and be able to circumvent the bullshit broken system that you're so upset with and shut up about the problem and be the solution.
heard that.
So what I'm saying in a roundabout way is thank you.
Thank you.
Well, that means a lot. And there's been,
Yeah.
it has been a journey. But I think if people can, talking to whoever is maybe in the same position, I was scared shitless before I left because I'm like, I'm not going to have freaking insurance. Like, how am I going to do this? I was 7 months pregnant with my second child before I opened my practice. I'm like, there is no effing way anybody's going to trust me.
Because you were fat?
Okay, that's a good one.
Thank you, God, for laughing. Thank you for laughing.
I have two older brothers, so I
so offensive for so many people.
Coming. I'm more disappointed that I didn't expect that coming.
I didn't see it coming. I don't see anything I say coming. It just comes right out.
But if
anyway.
anybody is actually thinking about doing it, like, I have no problem talking about, how to get to this point. And I don't know everything. I'm open to learning more. But the fact that I'm really trying to close the gap between healthcare and the fitness world, like, I'll connect with local trainers who are training my patients and say,
that's great.
Are they feeling like a pancake when they walk in the door? Like they can't do shit because they're tired or they're having side effects. I need to know about that so I can adjust their nutrition so they can show up and put more intensity into what they're doing. I don't know why more people aren't doing that. I don't know if it's like they're assumingly afraid what trainers are going to think, but it's finding that support group who, like you, are like-minded and say, hey, we have seen the positives that come from these medications. Open up to the possibility that these could be life-changing for 3 of your patients. And I'm sure maybe 3 people come to mind that work their ass off and they just don't see those changes happen. And then think about what they would be able to do with a tool like this. Yeah. And that's what makes it so fun for me. But also being able to have these relationships with patients where they're like, okay, I keep coming back because what I'm dealing with. It's not like a Weight Watchers where you watch a PowerPoint, right? And then you get a script and then that's it. It's more of that connection. So thank you. Anyways, I appreciate it.
I love it. Thank you, Jenna. We know that we were just introduced a few days ago and you had a short amount of time to prepare by saying, what am I getting into with these guys, and listening to some episodes. Have you listened to an entire episode all the way through?
No.
Typical guest. 170 guests and only 2 have known the final question. We ask every guest on this show the same final questions so that we can compare and judge you to all of our previous guests. Are you ready for our last question?
Yes.
Bye-bye.